Our research question is, how does high-risk pregnancy affect an immigrant family's physical and emotional well-being?
For our synthesis project, we will consider high-risk pregnancy as any issue where the life or health of the mother or infant is threatened by a disorder unique to pregnancy. We will consider immigrant families as those who are eligible for residency, including family class and economic immigrants, as well as government-assisted and privately sponsored refugees. We'll be using this definition as much of our research did not differentiate between immigrants and refugees. We will also consider both immigrant families not covered by OHIP, which would be those living in Canada for less than 3 months, and those who are covered by it, which would be those living in Canada for more than 3 months. Immigrant families are a vulnerable population because they face many challenges in regards to access and navigation of the health system, more specifically, maternity care services. A lack of access puts this population at risk for late diagnosis of high-risk conditions, which lead to issues that affect immigrant families disproportionately more than non-immigrant families. In fact, it is found that immigrant families are involved in 24% more preterm deliveries, 50% more perinatal mortalities, and 61% more congenital malformations. This is significant to healthcare as hospital costs for preterm births alone are 9 times higher than those of term births. With that said, it is both economically and ethically beneficial for us to fix the barriers this population faces in regards to their challenges with high-risk pregnancy. This is why it's important for us to take a population approach and fix this issue with upstream interventions. We can also address this issue as it's happening, as nurses play a huge role in the determination of health for immigrant families facing high-risk pregnancies. Research has found that practice of culturally sensitive care with these families can mitigate many potential issues associated with high-risk pregnancy, including life-threatening incidences. This is just one of many nursing practices we can use to protect the physical well-being of this population. The emotional well-being of these families is also something we need to discuss. Antenatal depression is an issue strongly associated with social and environmental stressors, issues significantly affecting immigrant families. Research has found that antenatal depression rates with immigrant women are at minimum 1.5 times and at max 3 times the rate of non-immigrant women. This is important as depression during pregnancy has been associated with poor maternal health behaviors, such as tobacco use and poor maternal weight gain, and this leads to more adverse birth outcomes. The fathers of these families had their own emotional issues that needed to be taken care of as well. Fathers distressed by high-risk pregnancies had a higher likelihood to practice negative coping behaviors like alcohol abuse. With that said, we need to target this issue from every angle in order to facilitate health and accessibility for this population. This can be done through a population health approach, through the reorientation of practice of healthcare providers, and by taking into consideration the effects high-risk pregnancy has on the whole family.
While conducting our research, a vast majority of immigrant families expressed their concern of access to healthcare, as OHIP coverage begins 3 months after immigration. Prior to this, immigrants can utilize private health insurance, although this is often a costly option. After this 3-month period, when OHIP is now active, financial status still affected immigrants' use of prenatal care. Families were not aware of universal accessibility, therefore lack of money is a barrier to seeking care. In addition, OHIP does not cover costs for translation services, creating a language barrier between the healthcare provider and the patient. It was discovered through our research only some hospitals in Canada may have this service available to patients. Along with this, lack of adequate resources was another structural barrier. Lack of transportation and the cost of transportation were other barriers. Immigrant families expressed frustration with public transportation, high parking fees, and clinics being far from their homes. Furthermore, having a high-risk pregnancy meant more visits to the hospital for weekly appointments. Therefore, family members would lose hours of work, which would increase financial stress on the family. Low socioeconomic status was a barrier, as these families were less likely to receive prenatal care, specifically during the first trimester. The literature interventions suggest to develop a comprehensive understanding of pregnancy health and social needs of low-income immigrants towards informing the development of telehealth. Pros of this intervention includes accessibility to those who have access to a mobile device. One of the cons is that low socioeconomic families may not have access to internet or phones.
Education and literacy directly affects immigrants' families' access to healthcare and job status. English as a second language makes it difficult for immigrants to understand the new healthcare system and the medical terminologies used by healthcare providers. Immigrants also face difficulty communicating with healthcare providers, which directly correlates to immigrants' lack of adherence to medical advice. This lack of understanding causes pregnant migrant women to have a higher risk of adverse health outcomes during the delivery process. For many immigrants, educational degrees obtained in their home country did not meet Canada's standard of education, thus affecting their employment status. This forces migrant families to work low-paying jobs or to go back to university or college to acquire a higher-paying position. Literature also shows indirect discrimination was evident when healthcare providers would refuse to see immigrant families if they did not bring along their own interpreter. Current care resources available in Ontario are limited for the immigrant population, since majority of the websites are only offered in English and French. For example, the Government of Canada website and the Ontario Prenatal Education website is only offered in English and French. However, we found a website called medalineplus.gov. This provides general health information in multiple languages for free. Though this website provides translated documents, English is needed in order to navigate the website. In addition, immigrants may not have access to technologies needed.
Another social determinant of health found in the literature was cultural barriers. Language barriers and feelings of isolation were common social cultural complaints. Immigrants would combat this by maintaining cultural traditions and beliefs in order to feel connected to their families back home. This connection to their home country was an aspect that many healthcare providers were unsympathetic towards and felt that it was not within their scope of practice to inquire about them. Healthcare providers also showed to have biases towards immigrants, which in turn had an effect on their care. This could be seen in midwives who thought that immigrant women were having children in order to receive more government family allowance, with no indication of whether this was discussed or addressed with families. It was also noted that if some expectations of care were not met due to the physician's failure to recognize the cultural needs of the client, clients were less inclined to continue care and would begin seeking care elsewhere. This resulted in some health issues going unaddressed or taking longer than necessary due to inconsistencies. Providers also have their own expectations of prenatal health care that is based upon the Western medical model, including the timing of the first visit and the number and frequency of subsequent visits. This conflict between patient and provider expectations of prenatal healthcare can be problematic and act as a barrier preventing immigrant families from accessing and receiving prenatal healthcare. Interventions found in the literature to address these issues range from individual practices such as self-reflection done by the healthcare providers to community-based actions like cultural safety programs with a focus on personalized women-centered care. Another intervention was to implement community-based doulas acting as cultural bridges to provide information on different cultural birthing customs. For example, they could help with the organization of a cleric to come and conduct religious traditions and prayers for a family in the hospital. These doulas could provide a sense of cultural support for the immigrant families, and as well they could help with translating. However, availability and costs are in question as they may be financially inaccessible due to the fact that they are not covered by OHIP.
Another social determinant of health commonly found in recent literature was a lack of social support. Social isolation, loss of pre-existing social support systems, and separation from family was shown to exacerbate worries from both parents related to their high-risk pregnancy status. On top of social isolation, environmental and structural factors affecting mental health, fear of loss of pregnancy, concerns for own health, and uncertainty regarding the future of the family's pregnancy increased depression and anxiety. These issues leading to increased stress were oftentimes internalized by family members due to lack or absence of social support. Internalization as a coping strategy has shown to reflect the highest levels of distress compared to any other coping strategy, which lead to a cascade of different issues affecting the family's health. For immigrant mothers, this was associated with higher rates of antenatal depression, as more than 1 in every 3 immigrant women were diagnosed with it. Both the lack of social support networks and prevalence of antenatal depression has directly correlated with ineffective coping skills, such as tobacco use or poor maternal weight gain, which is both shown to lead to more adverse birth outcomes. For fathers, a lack of social support correlated with an increased occurrence of depression and a higher level of alcohol consumption. It should be noted that this was found from an article that was not based on immigrant populations. However, we can make connections with the minority stress model, which suggests that stress resulting from social isolation is a contributing factor to alcohol consumption among the immigrant population. Researchers found that the creation of social groups has been effective to address both the lack of social support and increased rates of depression with this population. This would include the interaction and support from other families currently experiencing high-risk pregnancies or from those who have already been through it. One advantage with this intervention would be that it has been found to be strongly associated with decreased stress and has been supported and suggested by multiple pieces of literature from past to present. Another advantage would be that family support comes from people who have already been through or is currently going through the same health issues as them, and so there may be an increased empathetic connection. This intervention would also give immigrant families an outlet, which removes the coping mechanism of internalization and increases their social support systems. There are also already multiple community-based support groups that exist in Ontario, which can be found on womenshealthmatters.ca, toronto.ca, and canada.ca. These support groups usually offer free transportation as well, and having it community-based is a great way to facilitate cultural needs for this population. One potential issue with this intervention would be that organization and attendance may be an issue due to the need to work and other life priorities, which is especially true for this population. To address the high levels of antenatal depression with this population, literature suggests a thorough psychiatric assessment for women who have a psychiatric history. One advantage to this is that it may identify and help women who are at risk for antenatal depression, as those who have a psychiatric history are at increased risk for this. An issue with this recommendation is that it ignores women who show depressive symptoms without a psychiatric history. Studies have found that 58% of high-risk pregnancy patients have manifestations of depressive symptoms, regardless of psychiatric history. In a study of 82 high-risk pregnancies, 77% of women actually stated that they would have benefited from psychiatric help. One study recommended that supports be built for fathers who felt unsupported, encouraging couples to talk through issues and to educate fathers on their new roles. Some advantages with this recommendation is that it accepts the idea that high-risk pregnancy impacts the family as a whole. It facilitates communication in families, a factor of resilience, which may strengthen family cohesion, and it supports fathers, which would decrease stress, therefore removing the need for maladaptive coping mechanisms. The problem is that this is based on old research. This leads us to gaps in knowledge that should be considered. The research that gave us this recommendation was done in 2007. We need more recent literature based on immigrant fathers and how they cope with this issue, as this population is at risk for ineffective coping strategies based on the minority stress model. In order to effectively help fathers, we need to understand their problems, which necessitates recent literature. We also notice an absence of research showing how high-risk pregnancy affects immigrant families with differing sexual orientations. This may be a form of heteronormative belief that undermines the potential for diversity of immigrant families. This ignores the framework of intersectionality within culturally safe care, and has the possibility of marginalizing these families even further. With that said, we concede the idea that there may just be a lack of these families to study. There was also a lack of research on the family dynamics of how immigrant families as a whole are affected by high-risk pregnancy. Considering this, we were only able to provide information based on individual members with the family as context or in the context of society. With the insufficient literature on this subject, we were unable to examine and consider the family as patient.
For education that we came up with is a free, easy, accessible app that would connect immigrant families with healthcare providers. These healthcare providers would be educated in several languages and have cultural and sensitivity training. Through this app, we can provide basic prenatal care, warning signs to look for, and have a 24-hour chat available for any questions. This are immigrants may not have access to technologies needed. It could also be difficult to find healthcare providers that speak multiple languages, and it's extra expenses on OHIP. Pros are, this upstream approach is a way to reorient healthcare to increase accessibility for this population.
For our interventions against cultural barriers, we suggest that hospitals incorporate cultural sensitivity workshops with a focus on the predominant ethnic groups within the catchment area. This would force hospitals to go out and identify the patient population and their needs. These workshops are meant to address the disrespect felt by many immigrant families due to the absence of culturally sensitive care within the hospital setting that actually decrease their chances of returning to the hospital. This intervention would help healthcare providers meet the needs of many immigrant families within their population. However, these workshops may be too generalized for certain subcultures, and thus further action would need to be taken to meet the needs of those subcultures.
Another intervention we recommend would be an appointment-based community nursing strategy that brings nurses to the houses of our population. The nurse would determine what psychosocial supports the family needs at each visit. As we brought up, accessibility due to the need to work or transportation costs has been a big issue with these families. This proactive reorientation of health services would allow us to avoid these barriers. This would also give families the opportunity to speak about their issues with someone, as social groups are at times inaccessible to this population due to differing life priorities. This would in turn decrease internalization and possibly help in decreasing the prevalence of antenatal depression. The cons would be that the cost of transportation and for nurse deployment may be high.
Our intervention for income and social status is, we thought it would be beneficial for this population to have a free translation app since translation services are not covered by OHIP. Pros are free access to translation services. Cons are translation may not be accurate and there may be a lack of access to technology.
To conclude, expectant immigrant families face many challenges that contribute to lower familial health outcomes. As seen in our presentation, socioeconomic status, education and literacy, support networks, and culture all contribute to how effective families accessed and navigated through our healthcare system. As future nurses, we play a large role in advocating for the holistic care of all our patients and need to recognize their cultural needs. Through our interventions, we will be able to educate, inform, and tear down barriers that occlude access to our universal healthcare system, thereby improving the overall health and emotional well-being of expecting immigrant families. We hope that you found this video enjoyable, insightful, and that you were able to learn something new about expecting immigrant families coming to Canada. Thank you for listening.